All right, welcome everyone. Thank you so much for joining today's webinar, The Fierce Urgency of Now, Policy Action Needed to Address HIV and AIDS in the Black Community. Before we begin, I want to go through a few housekeeping items. Today's webinar is being recorded and we will share the recording with registrants following the session. If you do have any questions during today's webinar or technical issues, please email tuskegee@signaldc.com. First, we will hear the keynote address, Stemming the Tide of HIV and AIDS in the Black Community with Whole of Society Engagement from Dr. Reuben Warren, Professor of Bioethics and Director of the National Center for Bioethics in Research and Healthcare at Tuskegee University. After his address, we will watch a short video, Empowering First-Time Authors with Inclusivity and Peer Review Guidance, a moment with JHSH Special Issue Authors. And last but not least, Dr. Jasmine Ward, CEO of Black Ladies in Public Health, will moderate a panel discussion titled Maximizing Our Moment to End HIV and AIDS in Black Communities with Intersectional Policy and Programmatic Solutions. And with that, I will turn the webinar to Dr. Reuben Warren.
Hello and welcome to today's webinar. The fierce urgency of now, policy action needed to address HIV, AIDS in the Black community. Stemming the tide. I'm Reuben Warren and I direct the National Center for Bioethics and Research in Healthcare at Tuskegee University. The center is the only presidentially mandated bioethics center in the United States. It was established as a part of the 1997 presidential apology for the United States Public Health Service syphilis study at Tuskegee. Many of you may know it as a misnomer, a misname, the Tuskegee syphilis study. Since 1999, we have worked tirelessly to eliminate various ethics violations, bioethics, public health ethics, virtual ethics, and others, particularly as they adversely affect people of color. I recall in the early years of the HIV/AIDS epidemic in the United States and around the world, the infection, disease, seemed to be targeting specific population, and the public health community and the bioethics research community response was very slow. By 1992, HIV and AIDS became the 7th leading cause of excess deaths in the Black population. The other causes were cardiovascular disease, stroke, cancer, diabetes, cirrhosis of the liver, unintentional and intentional injuries, and infant mortality. In 1985, there were 60,000 excess deaths among the Black population, compared to our non-Hispanic white counterparts. In 2005, that number of excess deaths had increased from 60,000 to 83,000, due primarily to deaths among Black men. The increases were in homicide and HIV and AIDS. This is a timely webinar. Here we are in 2022, dealing with the same issues. There is a fierce urgency of now, and we will repeat history unless we do something and do something now. Nearly 2 years ago, my colleague, Dr. Vivian Carter, chairperson of the Department of Sociology and Psychology at Tuskegee University, approached me about co-leading a 2020 conference on the depth and breadth of HIV and AIDS in the Black community. The conference was held on the historic campus of Tuskegee University. You may know that in 1915, Booker T. Washington and Monroe Work established Black Health Week, which is now Minority Health Month, held April every year. There could be no better place than hosting such a conference than on the campus of Tuskegee. The extraordinary passion, engagement, momentum from the conference was the impetus for publishing a special issue in the peer-reviewed Journal of Healthcare, Science, and the Humanities, owned and published by the National Center for Bioethics and Research in Healthcare. This special issue addresses the plethora of challenges and opportunities, including public policy development, particularly related to HIV and AIDS and the Black community. That's why we are here today, and I'm so pleased that you've joined us. This special issue does not mark the end, but the continuation of a movement. It is a launching pad for policy development to end this disproportionate burden of HIV and AIDS on the Black community. I'm very pleased with the authentic partnership between Tuskegee University and Gilead Sciences. With Gilead's support, we have worked very closely together to assure the special issue and this webinar that we reached the right people in the right places at the right times. You are a virtual audience, so you can see, you can tune in. Due to the coronavirus pandemic, more of us are virtual, even though we need to do much more to expand the bandwidth for many, many others. In addition to this historic webinar, this is Black History Month. What an extraordinary way to end a month of celebration, reflection, and commemoration. As you all are well aware, in 2019, Black people represented 13% of the US population, but 40% of people living with HIV and 43% of HIV-related deaths. With these simple statistics, it is clear that health disparities, health inequities, and excess deaths continue, and the disproportionate burden of HIV and AIDS in the Black community is worsening. To that end, we must engage and resource congressional leaders, faith-based organizations, Black-led community organizations, and historically Black colleges and universities to end this epidemic. And some argue to end this pandemic. We know that 90% of all historically Black colleges and universities are located in or near predominantly Black communities. Yet the funding for research and program development allocated for HIV and AIDS research is often provided to predominantly white institutions. That's a disparity. That's an inequity. Despite the staggering overrepresentation in the Black community in the number of persons living with, at risk or living with HIV and AIDS, our communities do not experience the same investment and support as our non-Hispanic counterparts. That's an ethics dilemma, an ethics problematic. It is imperative, nonetheless, that we acknowledge the strength and historic Black colleges and universities and their faculty and the communities they serve, as we are key to successfully ending and improving health outcomes from this historic and tragic disease. We must also prioritize ethics partnerships between institutions and individuals to impact public health policy related to HIV and AIDS in the Black community. We must focus on federal, state, and local community partnerships to implement the national HIV/AIDS strategy in ending the HIV epidemic and achieving those goals. And we must all, and most of all, we must all assure that people who with lived experience, people living with HIV, people in the Black community, and people with their boots on the ground be at the table, the discussion table, to discuss these issues. We alone as academicians and public health professionals cannot end this epidemic. I'm particularly proud of the special issue as Dr. David Hodge, Associate Director for Education at the Center and Associate Senior Editor for the journal, sought to do just that by empowering first-time authors. Dr. Vivian Carter is the guest editor to this issue, and we are pleased with her contributions. Dr. Darrell Scriven, Dean of the College of Arts and Sciences at Clarkson University in New York, provided extraordinary leadership during the peer review process, a very rigorous process. The editorial staff made every effort to ensure that authors could publish their work while also adhering to the peer review process. This is virtual because first-time authors, it's virtual and critical because first-time authors, especially those who are outside of the academy, think of some of the best answers and clearly provide some of the best questions. They are driven by a different outcome than academicians. We are driven by publish or perish sometimes, but those not in the academy are driven by a different calling. To truly impact the pandemic, we need to hear from the voices we do not usually hear from. Those of us in the academic need to do a better job at listening. We need to incentivize those who are in the community that we need to serve. They need to share their stories from the ground so that we and other places can develop a better research agenda. For this issue, there were approximately 28 abstracts submitted for review, resulting in 20 being approved for full manuscripts. 17 of the manuscripts were approved for publication. And after a very rigorous review process, of those 17, several were first-time authors. First-time authors. That's incredible. I applaud their drive outside of the box and their thinking outside of the box and their courage. Inclusivity of the peer review process was also prioritized. Among the 60 participating authors, there were many underrepresented racial and ethnic groups who submitted. In my view, HIV and AIDS is grounded in social engagement. And as a result, we must be involved in social engagement in order to assure that the well-being of individuals, groups, and communities, regardless of their demographics, are respected and listened to. I hope that this webinar, grounded in this special issue, will further advance what you know and empower us and empower you to create and advance public policy related to HIV and AIDS in the Black community. Because of you, we are a part of the whole. And without you, we're incomplete. We cannot stem this tide of HIV and AIDS in the Black community without your help and support. And with that, I'd like to share a short video with you before turning you over to my friend and colleague, Dr. Jasmine Ward, CEO of Black Ladies in Public Health, who will moderate our exemplary panel. Please enjoy the webinar, and thank you for joining us this evening.
For me, this special issue highlights the variety of voices of the HIV community.
The purpose of special issues is to bring awareness to a pandemic that has been around for decades, that's killing Black and brown people, and it appears that there's not as much attention given to it as there should be.
So the work that I published in this special edition actually looks at HIV testing among Black cisgender and transgender women.
The research I completed was to examine the relation between age and various cervical cancer screening strategies on HIV-positive women in Kenya.
I wanted to publish in this special issue specifically because it's dedicated to unpacking the different sociocultural and structural issues that are actually driving the disproportionate rate of HIV in Black communities. But it doesn't just stop there. It also focuses on papers that strategize recommendations to improve these drivers of HIV in the Black community.
This journal helps to create awareness, not just in terms of social awareness, academic awareness, but in terms of public policy. The goal is to get this journal in the hands of those people who can make decisions and who can impact the lives of those who are the least, the lost, and the left out right now. It is vital to be inclusive of first-time authors because everyone needs an opportunity, everyone needs a chance. We need to understand that so much of academia is publish or perish. If journals are rejecting people more than they're helping people publish, then that is unhelpful to the overall conversation.
We all have to be part of creating new opportunities, especially for minority students, people that sometimes get left out, in this case, potentially targeting our efforts in historically Black colleges and universities, where we have the next generation of leaders who are looking and passionate about research, but just are not availed to the same kinds of opportunities.
We try to make sure that first-time authors, all authors, but first-time authors, that we give them a clear, very hands-on, conversational movement through the process.
The process to publish in this journal was extremely straightforward. I found the editors and the editing team to be extremely communicative. So anytime they had feedback, they gave it to me. It was meaningful, and they just communicated really well throughout the entire process. It just kind of helped to push this along.
People don't change what they don't think is a problem. And so in order for us to reduce barriers, we have to first acknowledge that there is a deficit of research that's coming from certain groups of people. In this case, we're talking about African American communities.
That's a beauty, I think, of this particular special edition, is that it does provide this broad array of voices.
In order to create opportunities and reduce barriers, those that sit in positions of authority have to re-examine the value of the stories that are being told in our communities.
There are a whole lot of brilliant minds in the conversation, especially young minds coming up that their minds are sharp, they're just being trained, and they have a whole lot of things to say. But if those governing the process that would allow these persons, these writers, to be published, then they are constrained in certain ways, and that seems to be oppressive to us. Many journals, they have so many papers coming in that certainly they can't publish everyone. So they have to reject some, and then they may not have the team or the staff to help someone publish. So what we do is, with our authors, is we work with them and give them the support they need to ensure that their work is sharp.
So I'm thrilled about what we were able to do. I'm thrilled about the support that we were able to get with Gilead, along with the Tuskegee National Center for Bioethics.
It is my hope to help bridge the gap between my community and those in public health, as it has been stressed for much too long.
I believe we can do it. We just have to do it together.
Wow, thank you so much. That was amazing. I'm so proud of the effort that went into making this special issue, not only a resource, but an empowerment tool for the first-time authors. Thank you again. Hello, everyone. My name is Jasmine Ward. Thank you for joining us today. We have an exciting panel of HIV and AIDS experts. So let's go ahead and dive right on in. I'm the CEO of Black Ladies in Public Health, a network of about 15,000 public health affiliated Black women who serve as a critical resource to the issues and communities we touch. We connect people and organizations that prioritize the health and lives of Black women and families. I'll be moderating today's panel. First, I think it's befitting that we find out more about our wonderful panel. I'll have you all please turn on your cameras and unmute and share 1 minute about who you are, a brief background, and what your current role is in ending the HIV epidemic. First, we'll start out with Harold Phillips.
Hello, there it is. The camera was a little stuck. Hi, I'm Harold Phillips, and I am the director for the White House Office of National AIDS Policy. And I'm extremely happy to be here and really excited about the work that we're doing together. Thank you.
Thank you. Next, we'll have Dr. Puckrin.
Hello, and thank you so much. I'm Gary Puckrin. I'm president of the National Minority Quality Forum. We are a research and education organization based here in Washington, D.C. Our work is really focused on collecting health data. We've been doing that for 20 years. We have a database of over 5 billion patient records. We collect data on about 100 60 million lives per year, covering well over 100,000 different conditions, and HIV is certainly one of the conditions that we collect data on.
Wow, thank you. Dr. Gibson?
Hi, Jim Gibson. I'm the CEO of My Brother's Keeper at Open Arms Healthcare Center located in Jackson, Mississippi. Our role has been dual. We've done community events, we do community outreach, we do trainings, education around HIV prevention, HIV care, but we also serve as a primary healthcare clinic. And as a primary healthcare clinic, we have been able to increase access to PrEP, to care, and we do this through our mobile clinic. We also do it through telehealth, and we also have face-to-face services.
All right, thank you. Dr. Jones.
Yes, good afternoon. My name is Shonda Jones. I am an executive director for academic programs at Wake Forest University. Also the principal investigator at the School of Divinity at Wake Forest for the Compass Faith Coordinating Center. The Coordinating Center works with a variety of faith communities and houses of worship to address HIV and AIDS in the Southern United States. We have been doing that by building the capacity of leaders in faith communities through virtual trainings and building toolkits for a variety of audiences to address HIV and AIDS.
Thank you. I want you all to know that's very difficult to do in 1 minute because you all are doing so much. So thank you again for joining us today and taking time out of your busy schedules. We have a lot of questions, but I'm going to try to get to the ones that I think are most pressing. So we're going to start with you, Harold. So COVID-19 has exacerbated existing disparities and nearly eclipsed everything, including our national response to HIV. How will federal partners ensure that we are making progress towards reducing HIV-related disparities and inequities in the Black community?
Sure. And thank you, Dr. Ward, for that question. Here at the White House, we have released the National HIV/AIDS Strategy for 2022 to 2025. In that strategy that President Biden released on World AIDS Day back in December, it prioritizes the African American community as a community that is disproportionately impacted by HIV. It also outlines a set of strategies and objectives, not just for our federal partners, but it's a whole of society effort, because we can't do it alone in just the government. We need our business sector, we need our academic institutions, our community-based organizations, our faith-based organizations, all paying attention to this. You know, as 13% of the American population in the year 2018, we were 42% of the HIV and AIDS cases for that year. And, you know, as we all have seen through COVID-19, we've seen the impact of both disparities as well as structural and systemic racism in our community when it comes to access to healthcare, knowing your HIV status, getting in care, staying in care, which might be impacted by lack of housing or transportation or not being able to have childcare. So our national strategy calls for a whole of society effort. And we also have indicators that we are measuring and holding ourselves accountable as the federal government for moving the needle in a more positive direction for our communities.
Thank you for that. That was amazing. And I think that it's important that we do note some of the things you mentioned about the importance of community organizations and faith-based institutions. And certainly we understand, obviously, that we have to really think about who's making these policies and allowing us to really get to where we want to go. And so, Dr. Puckrin, you have a lot of expertise in this area. What should Congress, particularly members of Congressional Black Caucus, do to ensure people living with and those vulnerable to HIV aren't left behind in our national recovery?
So for us, it always starts with the data. There are roughly 38,000 zip codes in the United States. 70% of Blacks live in 2,500 zip codes. So the HIV challenge that we're talking about really is occurring in 2,500 zip codes. We have the data on those 2,500 zip codes. Many African Americans are in the Medicaid and Medicare program, so that data is available from the federal government. We have a clinical understanding of how best to manage HIV. So the resources are there. What we like to do is aggregate the data up by congressional district. So when we go into a member's office, we can say, here are the number of people in your district with HIV. Here's what their outcomes look like. Here is the prevalence and incidence of HIV in your community. How can we collaborate to do better? Now, one of the challenges is that little understood is that African Americans live in districts both Democrat and Republican, and that's all I'm going to say. And so you understand the challenge that we're living with. About 40% of African Americans with HIV live in a Republican district. And so therein lies the challenge for us all.
So you're showing up with the receipts, as my friends would say, right?
Yes.
Okay. So I do have another question for you. What is the role of HIV stakeholder community in ensuring that HIV remains a priority?
It's all about advocacy. If you ain't advocating, you ain't getting. And so we strongly urge that we have to advocate for the HIV community. Advocating is part of healthcare now, so it's incredibly important that we raise our voices and make sure that quality care is available for those with HIV.
Thank you. So, Dr. Gibson, we know we have to show up with those receipts. We have the data that's out there. What is the critical role of AIDS service organizations and community-based organizations such as My Brother's Keeper in addressing HIV in the Black community, particularly in non-Medicaid expansion states?
Well, I see our role as leaders. I mean, mind you, we have been in this work for so long as community-based organizations, and we're the navigators. I mean, we navigate all these other entities through how to get through the community, and particularly in the Black community. And the skills that we have, I mean, they've been cultivated, they've been refined, they've given us the presence in the community. And a lot of this is done with and without funding. So as leaders in this, I think it's really important that community-based organizations, take the role as leaders, and we have the ability to think outside the box. We have the ability to be visionaries in this. And because we have the ability to be flexible to the community needs, we should be the voices. We should be what people are listening to, who people are listening to, on how we can actually do this work. You just can't throw money at it. You have to bring people who've been tried and true into this process. So I see ourselves as the leaders in this. And I think that if we come to this mindset that this is a valuable entity that can help with this process, I think it can just change it. It can make sure that what we want to happen actually happens.
I want to just pick up on something you mentioned about the possibilities and what should and could happen. What are some of the barriers that you face in doing your work, and what are some of the solutions from your point of view?
Well, the barrier is always going to be finances. I mean, money is going to be the thing that we're always constantly going to suffer from, trying to make sure that we have enough monies to be able to do this work. And, it's a barrier that as a community-based organization, you somewhat get accustomed to it. You get used to having to, find the money, get the money. It gets a little old, I have to admit, but we do know how to do it. But when you think about the importance of community-based organizations, and mind you, if COVID taught us nothing, you can have a beautiful vaccine and wonderful clinics, but if you do not have the community's voice to actually speak to the community, it'll fall flat. So if finances, that's just going to be the root of what stops us from being able to do our absolute best at the work that we have to do. And I think when I think about the solutions, I mean, there has to be some level of balanced funding. You can't take, what we do for granted. I mean, we are flexible, we are resilient, we have empathy, we have foresight, we have all these things that actually make things happen. So I think when we talk about how we can remove some barriers, let's give some equal compensation to community-based organizations. I mean, you can't do it without us. So you have to make sure that we can continue to grow.
I know that's right. Can't do without us. Well, one of the things I do think you mentioned, and you brought up is the value, how you're valued in this space. And so, Dr. Jones, what is the critical role of faith-based organizations and communities in addressing HIV in the Black communities?
Yeah, Dr. Ward, thanks for asking that question. I think faith communities in Black communities is so crucial, right? Faith-based organizations have long served as the cultural and political leaders in Black communities, spearheading social justice and change. At the same time, faith organizations have been sites of trauma and hurt, particularly for some of us that are most vulnerable, Black women and our LGBTQ plus siblings. So, you know, faith leaders who endorse more traditional notions of masculinity and heterosexuality. Some faith leaders, I should say, I shouldn't just say faith leaders, some faith leaders have been guilty of perpetuating stigma and silence around the impact of HIV in Black communities. You know, recent research has shown that there are more than 10,000 faith communities with members who are living with HIV. But there's been this slowing down of momentum of discussing the disease openly, with testing in faith communities and the like. But I think we have a responsibility, and this is the work of the Faith Coordinating Center. We have a responsibility to transform the narratives about HIV and people living with AIDS, and also those affected by HIV. And faith leaders and faith communities are at the center of that work, right? So what do I mean by that? So many of us that are in the pews, I happen to be an ordained minister, but so many of us in the pews continue to sort of sit under this sort of toxic theology, this sort of narrow view of sacred text, in which we who know better can help our leaders do better, right? So in Black communities, we're in this together, right? So I feel like there's opportunities for us to transform the narrative and not just leave it in the hand of that person who's considered to be the clergy person or the leader, but that all of us bear responsibility in telling a new story, singing a new song, right? And as attitudes have shifted, I think this is a pivotal time for us to re-engage faith communities about things that have been long taboo topics about sex, sexuality, and HIV.
Thank you. Now, you briefly mentioned the role that you all play in resourcing faith communities, but I want you to just give us a little bit more about the vision and approach of the Compass Initiative Faith-Based Coordinating Center, and how you're resourcing those communities.
Yeah, we have a lot of exciting initiatives that are underway. I get giddy as I think about it, because this is work that didn't start with us, right? There have been pioneers who've been really sort of grappling with issues of faith at the intersection of HIV. But one of the things I'll note is that we're working with national experts of religion and theology, but also in public health and in medicine, to educate and train faith communities to integrate scientifically accurate and theologically sound about HIV in their communities. How are we doing that? We are developing an ambassador program in collaboration with Old North State Medical Society, which is the first Black-led medical society in North Carolina. It's a group of thousands of Black physicians. So we're developing an ambassador program with those physicians alongside faith leaders to collaboratively train people of faith about ways to address HIV and stigma in their communities, and launch a statewide anti-stigma campaign. Other thing I'll mention, there are two other things actually. We're also mapping a national database, thanks to the help of our friends at AIDSview, of faith-based organizations doing HIV work across 12 deep South states to make it easier for people who are trying to find a faith-based organization with HIV resources in the area. The last thing I'll mention is we are in the midst of redesigning the Black Church and HIV website with the help of our friends at NAACP and others to provide self-paced online educational models and certificates to help people to have easy access to resources, right? So if there are faith communities who want to celebrate World AIDS Day, but they just don't know how to do that and what way they want to do that, this website will be a resource for them. They'll be able to get videos that they can play during their worship services, things like that. So we are, I'm just naming things at the tip. So this is just the beginning. This is the first year of our work. And so we're very excited.
Busy, busy, busy. Okay, well, this has been so informative. One of the things I will say is that you all have mentioned, particularly Dr. Gibson and Dr. Jones, just how important the work is on the ground, right? And Dr. Puckrin and Harold, you all have already spoken to some of the things that we see that are happening or needed and within the federal spaces and also in our government, so within policy. I want to go back to policy a bit. And Dr. Puckrin, I want to ask you what policies, solutions are needed to ensure that the needs of Black patients are prioritized, given that we know that Black communities are disproportionately impacted by HIV and face greater barriers to prevention, treatment, and care services.
So what we have to remember is that the healthcare system that we currently have, we refer to it as our legacy healthcare system, was born during an era when segregation and inequalities were not only permitted, but they were enforced by law. We started to bring down those structures in the 1970s and 80s, but a lot of that structure still remains. It gets articulated in we call it financial risk. So much of the healthcare system, at least here in Washington, when you're talking about healthcare, people are talking about managing financial risk and not patient risk. And so in the conversation about financial risk, they're comfortable with rationing care, and they ignore patient outcomes. So it's not just the problems that African Americans are having with HIV. I can tell you about diabetes and cardiovascular disease and kidney disease. It goes on and on. We need to give ourselves permission to reimagine this healthcare system. This is not a healthcare system that can provide quality care to diverse populations. It's not reformable. It was built and it's doing exactly what it was built to do. And so that's why the advocacy and the work and doing it by the numbers, because at the end of the day, healthcare is about science. It's about the numbers. It's about how do we use the numbers to reduce patient risk, not financial risk, but patient risk. So think about it. We know where the HIV community is in the African American community geographically. We know who's treating them. We know what they're getting treated with. We know whether they're staying in care and why they're not staying in care. So at any moment, we could intervene and stop this, but we're not. And the reason why we're not is because the financial system is thinking more about managing financial risk and not investing in community. And the only way we're going to change that is we have to advocate. We have to use our voice and our vote in order to change the system and build something that can really take care of our community.
All right, so.
Can I jump in on that just for a second? Because Dr. Puckrin is saying something that really resonated with me today, because I read a report that showed that 37% of the uninsured African Americans in this country live in Georgia, Florida, and Texas. And so when you think about what Dr. Puckrin is saying about sort of the health disparities, HIV, diabetes, cancers, and 37% of our population that's uninsured live in those three states that have not expanded Medicaid, it tells you something about the way Dr. Puckrin is talking about these systems that are structured and leaving people out, leaving them behind and endangering their health. And his call to action about we have got to begin to advocate for access so that we can at least have coverage for individuals. And then we can also continue to fight about making sure that coverage includes care that is culturally appropriate for our community.
Absolutely, and definitely taking note of the permission that has been granted by Dr. Puckrin to reimagine this system, right? So thank you so much, Harold, for even stepping in, because I do think that that's important. And one of the next questions I have for anyone who wants to actually answer, and actually I'd love for all of you to address it, what policy solutions are needed to truly make a difference in ending the HIV epidemic in Black communities?
Well, I'll jump in on that one, and I'll even add to the previous conversation. Not only do we need to reimagine healthcare, but we need to reimagine Ryan White care. I mean, mind you, that system was built and created on a whole nother mindset. HIV has changed. I mean, we have PrEP, we have treatments, prevention. And I think if we reimagine Ryan White care, we can also get rid of criminalization. Because again, at that particular point, it changes. And I don't think that as a healthcare system, are we paying attention to the fact that people are aging, and they're aging with all health disparities. And our healthcare system is not built for aging, it's built for babies, it's built for the youth. And so we have to rethink how we're doing it. So I think when we think about the policies, the way that we look at healthcare and Ryan White, that's directly related to criminalization. And we really need to rethink that policy. Something has to change to ensure that other entities, other powers that be, know that it has changed. And I don't think that they have. I think they're, in some instances, they think HIV has gone away, or that if it's here, it's just with this population. They don't know that we have new mechanisms, and that because we're living in the past, it's directly playing into how we treat people, how we think that their health is going to work out. I mean, the fact that we think that if you have HIV, you're automatically going to die, we've disproven that. So we're past that point. So I think in the policies, that's the one thing, reimagine Ryan White, and then we can handle criminalization.
Yeah, I think that's so good. So, I think Dr. Puckrin has already hit on this. In terms of policy, advocating for Medicaid expansion in states that haven't done it, I think is crucial to dealing with health equity issues. That decriminalizing HIV disclosure. I'll name one other that has to do with trans folks that are incarcerated with HIV. This is a policy issue where you have trans folks that are going to be incarcerated in prisons that in a gendered prison that doesn't match their gender. They're not often given access to all their medications for them to be healthy while they're in that system. I see that as a policy issue that needs to be advocated. For them to have access to being in the gender system, they can be in the gender system based on their identity.
Great points, thank you. Anyone else want to address the issue about policy?
I would just pick up the thread to say, in the same way that generations worked on civil rights and worked, we can go back to slavery, we now have to work on healthcare with the same commitment and energy. It's unimaginable in a society this wealthy that we allow people to walk around without health insurance, that we give them rescue care when it's too late for them to benefit from the care. And it's just not African Americans. There are others in the population who are suffering in the same way. And so we have to make that deep commitment and say, this is a challenge that we have to take on for the benefit of our community. And we have to be very intentional about it.
Thank you.
We got one time for one more policy change. One of the things that we are working on, especially as we exit Black History Month and go into Women's History Month, paying attention to what's happening with HIV with Black women who have new HIV infection rates 13 times out of white women and 4 times out of Latino women. And so working to ensure that comprehensive sexually transmitted infection prevention that includes HIV testing and access to PrEP for Black women in reproductive health settings would be an important policy change that we're trying to work toward as the Title X clinics reform and refocus their efforts so that we can bring these rates down.
I would just pick up to say social media, right? It breeds so much disinformation, but it can actually do some good, right? And so we can leverage minority populations, spend a lot of time on social media. We could use that to educate our communities, certainly to help them understand the HIV epidemic is not going out of our community, and we need to come together to figure out how best to move forward. And so there are a number of social media platforms and conversations that can be brought together to really organize ourselves to do something about this issue in our community.
Thank you so much. And I hope all of you who are listening in grabbed your pen and paper. I should have told you I have mine. I'm writing notes, and this has been very, very informative. Okay, so I'm going to ask one question before we head out for each of you to give us your call to action for people listening to the webinar. Y'all need to grab your pens and paper because this is going to get good. This is great. I already have so many notes. We'll start with you, Harold.
So I always encourage everyone to know your HIV status and talk to your friends and your family and your neighbors about if they haven't gotten an HIV test, get an HIV test. And have the conversation about the new HIV prevention medications that are out there and options for all of us that are sexually active. Black Americans are disproportionately not getting access to those medications or being offered even an HIV test. If you're not offered an HIV test at your doctor's appointment, ask for one, and then ask for why they didn't ask you in the first place. Why didn't they offer it when they did blood pressure and cholesterol screening? It should be part of routine, and we got to start asking for it as consumers of healthcare.
Dr. Ward, I know we're stretched for time. I just want to piggyback on what Dr. Phillips just said, that as a Black woman, I go for my wellness checks. I ask my doctor every single time for HIV test. And and you'd be amazed at the pushback that I get from physicians about getting tested. And then there's these systems that are in place. My physician showed me, when she asked for an HIV test, it puts a big red mark on her screen. She has to put in a reason why. He said, no other blood test do I draw in North Carolina doesn't make me do that. So there's some systemic issues related to that as well.
That goes back to that financial risk question that I was telling you about. The reason why they get that red mark is because it costs money, and they're managing the system through financial risk, and they're not thinking about patient risk. That's the formula. That's the hidden mechanism in the system that we don't understand, that we have to appreciate, and why we have to reimagine the system so that physicians feel comfortable ordering that HIV screening for you, ordering that diabetes screening for you. That's how the system is failing us. And you're lucky your doctor showed you the screen. Most doctors don't even show you the screen, so you don't know why that decision was made.
Right? It was this sort of self-advocacy, after she was like, well, why would you need that? I mean,
yeah.
I said, why didn't you ask me? Why didn't you ask me the sort of screening questions about my sexual health, whether or not I'm a IV drug user? None of those questions came up in my wellness check. I want to be well. That's why. That's my answer.
All right. And what strikes me about that, I'm glad you shared that, because I don't think that we understand that part of the system. That $75 test that would have saved or extended your life, or been able to have a conversation about, okay, well, let's do the test and then let's talk about HIV prevention, rather than you still be out there not knowing your risk, and we're at $20,000 a year for HIV medications later on down the line, when we could have done this $75 test. So Dr. Puckering talked about sort of the systems and some of the things that are embedded in it that we really got to understand better and dismantle. And Dr. Gibson talked about reformulating a system that works differently.
Yes, absolutely. And Dr. Gibson, do you have a call to action? What would it be?
I would ask that we re-educate people. Let's talk about the evolution of HIV prevention and care. Let's talk about where we are now, and let's relieve people of those old thoughts. I mean, we have methods now that we can actually, end this epidemic, and I think that requires the experts, us, the people who actually have the knowledge to, hey, you're sitting around the table, you're having Sunday dinner, just do some education. People are shocked to find out that there's PrEP. I mean, we see it every day. We live in the PrEP world, right, but there's so many individuals, in particular Black women, who have no idea about PrEP or PEP. So it behooves us to become the educators now, to tell everyone about it, show the evolution of prevention and care, and ensure that people have access. So that would be my call to action.
That's great. That's good. And honestly, this is such an important discussion. And I was just telling someone, When you work in this space, it seems second nature that you hear about these things all the time. But when I go out and do education and I'm talking to communities and people, Black women in particular, who have never heard of PEP or PrEP or any of the biomedical, even U equals U, any of those things, there's almost this feeling of as if we've kept something from them. And it's a visual response because it's like, if this is out here, why don't we know? And it is real. I've had people literally almost like I was keeping a secret. And I'm like, I'm telling you, I told you. So it's really important that we do realize that we have to also, I love the fact that Dr. Jones talked about all of those partnerships with organizations. And Dr. Gibson, you're right, doing the work in the community and getting to the people, but also educating our congressional leaders who may or may not agree politically with a lot of things, but need to understand that they can be educated and that we can reimagine the system. So I love all of the content and information that you all provided today. And it's so important that we continue to spread this information in casual conversations, normalize it. You know, my diabetes, you know, we can sit at a table and somebody, oh, my blood pressure getting low. We can talk about these things with no problem, but we can't talk about the issues that are truly advancing as it relates to HIV and AIDS, and understanding the lives that people are thriving, not just surviving, but thriving. And we need to recognize that and certainly provide examples of what it means to normalize and destigmatize some of this conversation. So I want to say thank you, first of all, for all of the work that you are doing. I think that 1 minute of an introduction just didn't do you justice. So I'm going to have my call to action for everyone out there. Please look up these organizations and the work that's being done. I know they were a little shy and modest about what they are really doing, but this is a superstar, all-star panel. So I just want to say thank you. I'm honored to be here. And I think that your expertise and input will inspire our audience. So I want to make sure that we have the opportunity for Dr. Warren to provide us with closing remarks. And so I'm going to go ahead and ask you all to turn off your cameras and we'll turn it over to Dr. Warren.
This has been a empowering conversation. If you think we don't know what to do, think again. If you think we don't know who can do it, think again. We don't need another conversation about what should we do. We need to empower those who are doing it. I'm empowered. I'm at the National Center for Bioethics and Research in Healthcare, and this has been an ethics conversation. And I am ready to move with the folk on this panel and beyond. And again, I can't say anything more than thank you. This has been a powerful session and it's only just begun. We are not ending, we are continuing. And HIV/AIDS is among the other things that we have to do. We're going to do them all. We're going to do them all together. This again has been powerful. I can't tell you how exciting I am about what we're going to do. Not only what we've done, but what we're going to do. And only way we can do it is do it together. And again, Dr. Ward, you pushed the panel to say what they wanted to say, and they said it. And I am again honored to be a part of this effort. Gilead has been authentic partners. Tuskegee, of course, has a history of doing what it does, and we continue to do what we do. And most importantly, those outside the academy continue to push us in the academy to do the things that you know we can do and you know we must do, particularly at HBCUs. And again, thank you so much.